Yeah. So, good evening, everyone. So, in continuation with our RPL series and also on the immunological aspects of recurrent pregnancy loss. So, this is one of the important aspects, and this was spoken in length in our workshop. At Project Pelvis 4.0, and many times, like we come across these HLA reports nowadays in patients who have had recurrent implantation failures and recurrent miscarriages, and it is very confusing to actually interpret such reports. And always, we kind of tell them the treatment as either LIT, endometrial scratching, IVIG, or intralipids or tacrolimus, just because we are unable to actually find interpretation because of this. So immune dysregulation has always been a part of, I think, recurrent pregnancy loss evaluation, and there is so much into it. HLA C type, HLA-G, there is KIR, and how to interpret the C1, C1, C2, C2, DBQ. So all those things are something which looks like Greek and Latin for many gynecologists, and this was actually a part of, I think, the transplant surgeons and transplant physicians profile. But now, since immunology is getting a lot of importance, and it is one of the emerging branches in gynecology, I think we all should know how to interpret, and we should not depend on, I think, physician or even like the transplant physicians to make an interpretation and to infer as to what the treatment is. So we had quite a bit of discussion over this in the conference, but this is just for people who did not attend, and also as an extension to what we have already discussed. So I would request not to go into the detailing as to what is HLA, C, G, and all those things, but to actually keep it very relevant clinically as to how we interpret C1, C1, C2, C2, HLA-G, I mean, and KIR.
Yeah. So I'll just start the screen sharing. I think probably the screen is visible, right?
Yeah, yeah.
Okay. So what is important for all of us to understand is I'll just open the photo here. So, life becomes very easy for all of us. Fine. So if you can see, I've enlarged the photo. Can you see the enlarged photo?
Yeah, yeah.
Fine. This is the only thing that we need to understand as far as this entire topic is concerned. Okay, and I will keep it very, very crisp. First thing, I want to tell you that this is a test which has been done by me. Okay. Second, if you see, very important, what is the specimen which is collected? It is blood. The normal reporting time for this specimen to sample is how many days? Simple answer you can give your patient is going to be approximately 10 days. Okay. Even if you don't know anything, you can answer that in 10 days you will get your reporting. How costly it is? Okay, it is very, very expensive. Okay, so let me not just go how expensive it is. It is really, really expensive. This thing for the couple is going to cost the couple approximately. If in case we do it for the couple, then at your best bet, it is going to cost them around 30,000 rupees. It's always going to be more than that. Okay, and it is expensive. So that is something which you have to keep in mind when you are advising this test to the couple. Now, this is what is very important that all of us should understand. Can you look at this HLA-A, HLA-B, HLA-C? And underneath that, you have written DRB1, DQB1, and DPB1. Correct? I have marked that in a different type because these guys are basically class 2 and the red one is basically class 1. Just don't worry about what it is. Okay? Just remember, just very, very, very simply remember that class 1 means self antigens. Okay? And this means foreign antigens. Bus, huh? Please don't remember anything else. I understand for the inquisitive ones, there is a differentiation between CD4 and CD8, but right now I don't want to get into it at all. Okay? Just remember this much. That is the reason when we do transplant, we want a matching between HLA-A, HLA-B, and HLA-C. And remember, our HLA-C, this guy, is the one which is going to be presented from the fetus to the mother. Okay, that is why this HLA-C is very, very important. Okay, now just look at this. These six genes are being studied, and we are going to study both the locuses of each of the genes. As a result of this, this word is important. 12. Okay, can you look at this? It is mentioned here. This 12 is very important. So we need to understand how many of these guys are matching to each other out of this 12. Very simple interpretation. Let me just draw it out and again show you. Can you see this interpretation? 21101. Correct?
Yeah.
Look at it in the female. It is not matching, no? 260101. Like
Mm.
that, if you see in entire thing, only this is matches. 40101, 40101. Correct?
Mm.
Rest everything is not matching with each other. Just if you just look at the report you study, you will understand. Look at this. This 100101 is not matching with 301, 1502 is not matching with 706, 401 is not matching with 702. Correct? No, nothing is matching. So basically, only as they have also told us, see, only 1 out of 12 is matching here. That means only 8% is matching. Correct? And this is very good. Okay, this is very, very good. Look at this. How much is the problem when it is matching? More than 50%. That means 6 out of 12 should match. That means it is a problem. But what do we take as a cutoff? We take as a cutoff as 5 out of 12. Okay. That even if 4 out of 12 or 5 out of 12 is matching, that means the probability of miscarriage is high. Understood this simple interpretation? Even if you don't know anything, you can just look at these alleles with each other and you can come to know acha, what is matching and what is not matching. Now look at this. Can you see this? Maternal type C2, C2. And look
Mm.
at this paternal type C1, C1. Now the remember one thing. When the paternal type is C2, C2, okay?
Mm.
And when there is something called as KR phenotype, which is AA, this is bad. Just one interpretation line. If it is C2, C2 with KIRAA, that means it is bad. Okay. Now to just give you a clinical context of this lady very quickly, she has had 6 abortions, everything unknown. Everything natural conceptions. No problem in the uterus. Uterus is absolutely fine. Everything is fine. Everything is fine as far as her immunology is concerned. Okay. This is one of those rare situations where HLA is fine, CDC is fine, autoimmune profile is fine, everything is fine. Basically, I made her spend this 30,000 rupees because every other report was fine. Okay, every other report was fine. So the take home point is when all the reports are fine, only then do the HLA typing as far as reproductive immunology is concerned. Do not go and do reproductive immunological evaluation with HLA typing as your first test. It is your last line resort. Correct? Now the question is very simple. Are bhai, this report is normal. How will you treat the patient? Correct. That is all. That is what we want to know. We don't want to know anything else. So remember one thing, friends, because everything is normal, because everything else has been tried for her, and she does not want to do IVF. If she wants to do IVF, I'm simply going to ask her to do PGTA, form a euploid embryo. Once the euploid embryo is formed, do a modified natural cycle, and in the modified natural cycle, try with tacrolimus. Why with tacrolimus? Because tacrolimus is a reserve drug. It is to be used when everything is fine. The same thing in this patient. Because every other report is fine, this is one of those patients in which I would consider to use tacrolimus as a part of her protocol after the lady becomes pregnant. That means after the UPT is positive, I would like to switch her to tacrolimus plus thymosin because she is an ideal candidate to try a reserve drug. Everything else has already been tried. That means she has been given steroid, she has been given HCQS, she has been given ecosprin, she has been given heparin, she has been given folic acid, she has been told everything, and nothing has worked on her. When nothing works and you don't know the answer, you are going to be trying to use tacrolimus, because all the 6 times she has had spontaneous conceptions. Okay. Now people really want to copy our protocol of tacrolimus and want to implement it randomly in their patients. Please remember, we give tacrolimus only in consultation with our transplant physician. Just in case you do not want to send the patient to me, it's fine. Send it to my transplant physician. They are very, very good at adjusting and calculating the dose of tacrolimus. I almost never interfere in their dosages. Okay. The only time I speak to them is when I want to step it down. That means when I want to cut down the dose of tacrolimus, especially after 9 to 10 weeks of pregnancy, till around 13 weeks of gestation, where we would normally want to stop tacrolimus. That is when I begin to interfere. So just keep that in mind. One more thing you should remember, please don't do or take a call on doing self LIT or donor LIT based on HLA typing reports. Trust me, guys, this is a patient who has got no requirement of doing LIT. Absolutely no requirement of doing LIT, because if you see her report, the HLA, that is class 2 molecules, any which ways don't match. Understanding? And if there is no matching in the class 2 molecules, it is going to give you no benefit of forming blocking antibodies in any situation. So please don't do that. Of course, there are multiple theories that, acha, if this is not matching, we'll do donor LIT, but that is all experimental. Had it been concrete, okay, then every one of us would have used it. Every one of us would have used it. It would be have been a no brainer. Okay. If you are a patient, and I understand today many patients have also joined in, if you are a patient, please understand and remember, you need not get carried away on your own by chat GPTing the interpretation of these HLA typing reports on your own. We do understand that you are super smart, we do understand that your talent is unbelievably real, but that does not give you a self interpretation of these HLA typing reports. You, as a patient, are going to do yourself much more harm rather than doing yourself any form of good. So, I humbly request all the patients who have joined to kindly go to your fellow doctors, seek opinions as to how you should interpret these reports and what would be the immunological benefit of any therapy at the end of these reports in your case. Okay. So with this, I finish and I'll be happy to answer 2 or 3 questions from Shilpa madam.
So in this C2C2 matching is the most, I think, the problematic one, right? I mean,
Paternal C2C2.
yeah, paternal C2C2. And can you tell like what is the maximum match you have seen? Like I have seen somebody who had like, I think 70% matching.
Yeah.
So,
I have seen people with 70 and 80% matching, and they have had 2 normal children.
so you think this polymorphism plays a very
The
important role
entire
when
game is of polymorphism.
polymorphism?
See, this lady has no matching and she has had 6 abortions. No
Yeah,
known
yeah.
cause, right? So
Mm-hmm.
must be something going wrong very severely down at the molecular level, no?
Yes, yes. So in such cases, like, who say that like I mean, say everything is like we have given tacrolimus, we have given IVIG, we have used thymosin and all such things, and then they continue the pregnancy. What do you think? I mean, how do you explain? Do you think like anyway they were destined to continue that pregnancy with or without?
God's blessings only at this moment.
So this KIR, does it come as a panel along with this HLA
It's a
or
same blood test. You can put it as an add-on. It will
add-on?
be costed approximately 17,000-18,000 rupees more.
But you don't believe in KIR as we discussed last time. You
No.
think that KIR is not a very important part of evaluation.
It really doesn't help. I mean, if KIR is AB or let's say KIR is BB, you've spent 25,000 rupees gaining nothing out of it. If
Yeah.
KIR is AA, you've still spent a lot of money doing nothing. With C2C2
Mm,
and KIR AA, that's the only thing which matters. So first you need to have a paternal C2C2.
mm,
The therapy for both is the same. You need to give tacrolimus. Then why
mm.
would you do a KIR phenotype and waste patients' money?
Mm-hmm. So in this situation, like, I mean, unless, like, see, your patient was able to conceive naturally, so it's a different thing. But in a patient who has conceived with IVF, and if they have had like more than two or three miscarriages, and if they are wanting to do a HLA typing, you think the PGTA should come first as a test, or do you think the HLA typing has to come first as a
For
test?
any patient undergoing immunological evaluation, the first rule is form euploid embryos. If you do not have euploid embryos, do not do immunological testing. Even if you get a good referral from the laboratory who is doing it, do not do it.
Yeah. So in one of the groups, we were discussing the same thing today, where they were discussing about, like, I mean, how in Indian population, even though there is a younger population than in the Western world, we are still seeing lot of aneuploid embryos, especially in patients who have had recurrent implantation failures, and also in patients with recurrent miscarriages.
Yeah,
So in your practice also, do you come across similar pattern where the number of aneuploidies are much more than, like, having immunological issues?
I don't think I'm the best person to answer that question, ma'am, because majority of our patients are at least one or two or three attempts
Yeah.
failed somewhere else. So I don't think I'm the best person to answer that.
Hmm. So in this PGTA, what we were discussing, I know it is out of context here, but in PGTA, you offer them even with one IVF failure, or if the patient is above 38 years of age as a first IVF cycle, if she is undergoing with you, do you recommend PGTA?
Age related, yes, but not a criteria for failed IVF.
Okay. Okay. So is there any way that, like, this other pathies like Ayurvedic, homeopathy, acupuncture, anything you think, like, is modifying the HLA in any forms? I mean, what is your thought process?
No science behind any of it, ma'am.
Hmm.
Nobody knows which drug would go and act at molecular level to change the polymorphism. I doubt if anything does.
So in consanguinity, you think, I mean, this is the same thing which actually plays up, like where the matching is too much, especially in like,
Correct. See, consanguinity also gives rise to such healthy children, right?
yes.
So the answer for that is polymorphism. Very simple. Till
Mm-hmm.
you really go down to individualized HLA-C typing, I think there is no interpretation beyond that at this moment in science.
Mm-hmm. Yeah, I think this was a good one. Any questions, we can take it up in our WhatsApp groups. So thank you everyone for joining on a Monday night for this session. So I thank Dr. Jay for his inputs on immunological aspects of recurrent pregnancy loss, where HLA typing is one of the most important test which has been done now, which has been done, misused, and also like overused in